everyone, welcome to Agents of Change Continuing Education. I'm Dr. Lauren Denley, and you will be spending the next hour with me learning about harm reduction approaches to substance abuse treatment, including clinical interventions and ethical considerations. So let's get started. First, we'll review our learning objectives. So we'll be defining harm reduction and its application to substance abuse. We'll be understanding the policy context to harm reduction as a strategy. And we'll be learning about the types of harm reduction interventions and their ethical implications. So more broadly, this is how we define harm reduction. So harm reduction is really a set of interventions with the goal of reducing problematic behaviors. So this applies to decisions that most often have negative consequences, such as substance abuse or other forms of self-harm. I have used this approach with eating disorders as well. So it's really important to understand that we're not pushing an agenda when we work with clients. However, when it comes to substance abuse in particular, sometimes there might be a tendency to become prescriptive or lecturing. So it's really important to highlight that harm reduction meets the clients in the middle at whatever stage they're in. It allows client-led decision-making for change. And if you take one thing away from today, I think the continuum approach, the idea of a continuum approach is really important. So the principle is to move the person along the continuum of risk from higher risk to lower risk. It doesn't mean completely eliminating behaviors. It doesn't mean that abstinence, if we're talking substance abuse, is the goal. It means that we're trying to move people from higher risk behaviors to lower risk behaviors, moving people along that continuum. So today we're going to be applying harm reduction specifically to substance abuse. And again, we want to really understand a stance of neutrality in which there's no shame or judgment for the client who is using substances. Policies and treatment that deal with substance abuse or poverty are fraught with, morality and policing and assessments about who's deserving and who's not, right? And harm reduction really seeks to, avoid that and try to work with the person wherever they're at and reduce shame. So this is a statement from the Harm Reduction Coalition. They define harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Again, important to highlight, it's a movement for social justice built on a belief and a respect for the rights of people who use drugs. That's going to be a really important aspect in terms of understanding the greater context of harm reduction. So the National Harm Reduction Coalition identifies 8 principles in applying harm reduction to substance abuse. I really wanted to include these principles because I really think it helps us set the stage to understand the foundational belief system that harm reduction is based around. So the first principle is that drug use is part of the world and we can minimize its harmful effects, right? So the war on drugs has failed, right? And it's incarcerated many more people than it's helped. So we need a different approach. We have to accept that, people are going to use drugs, and how do we help people move again down the continuum from more risky behaviors to less risky behaviors, even if that means not completely stopping using. So the second principle is that drug use is complex and exists on a continuum, right? So not everybody's drug use is going to look the same. And so, we need to be respectful and understand where the client is at and what's realistic for them in particular. Really important, quality of life determines success, right? So the main focus is on quality. How do we help move that person along the continuum while preserving or enhancing their quality of life? So it might not be the quality of life you want for yourself. It might not be the quality of life that you hope for another client, right? But it's that person's quality of life. If we can help them improve that's success. Number 4, services have to be non-judgmental, right? And not coercive. This is really important. Again, neutrality is central to this approach. Number 5, people who use drugs have a voice. I think people that are marginalized, particularly those who use, don't feel like they have a voice in their treatment, don't feel like they have a voice in society. And so we really need to remember and highlight that people who use drugs are people, plain and simple. So it seems obvious, right? But when we stop to think about some of the more harsh language that's been used to describe people who use drugs, who may also be people that are homeless or transient or mentally ill or disabled, it really bears repeating that people who use drugs are people. They didn't, wake up out of bed one day and say, oh, I'm going to, this is the life I want to live, right? People have a certain set of circumstances that contribute to using drugs to cope. So it's important as helping professionals to remember not to be overly paternalistic, but rather to make sure that these folks have a voice in their treatment. Number 6, people who use drugs can reduce their risks and inform and support one another with strategies that meet their needs. So there's community here, right? So we can encourage clients who use drugs to be the experts in their care, and also to learn new strategies to support themselves and to support other people in their communities. Number 7, harm reduction recognizes the impact of social inequality on drug use. So people who use drugs are often marginalized from society. They have less access to financial support that's needed to keep them healthy. Money for insurance, housing, childcare, mental health, physical health, access to healthy food, right? So we can't separate all of these things from the context of somebody who's using drugs. These are all really important aspects of that, of understanding the greater issue. Number 8, harm reduction doesn't minimize the harm that comes with drug use. So it doesn't say, using drugs is good for you, right? It doesn't negate, all the ills that come with that, both societally and individually. It's a different approach that is an alternative to the abstinence-only approach that you see with different treatment models. So I really wanted to include the policy context here. I don't think we can really separate that from when we're talking about the issue of drug use and working with clients that use drugs. There's no one national harm reduction policy. Everything varies, as with many policies, right? They vary state by state. There's some emerging trends. There are programs to reduce overdose fatalities. There's been more support for legal syringe access. There's been interest from law enforcement in utilizing harm reduction strategies. And there are some safe consumption sites in New York City and Rhode Island. The first injection site in North America was in Vancouver. If anybody's read Gabor Mate's book, which documents his 12 years of treating addicts within the system, it's called In the Realm of Hungry Ghosts. So it talks a lot about, how to treat this population in a way that's humane and attentive to their quality of life, and doesn't necessarily preach abstinence. So I wanted to add a little bit as an example of a recent policy effort here in Pennsylvania, which is where I live. There is an naloxone standing order, which permits pharmacists to distribute only the following formulations or their FDA-approved generic equivalent to people who are at risk of overdose. So naloxone is a drug that helps reduce overdose deaths, and it also, in Pennsylvania, the order includes authorizing community-based organizations to obtain and distribute naloxone to people at risk of overdose. You see it in the pharmacies. It's a strategy to help prevent overdose deaths. And if you can prevent somebody from dying, there's hope that they can, potentially reduce their risk or maybe get off drugs eventually if that's their goal. Um, so we always want to prevent overdose deaths as best we can, because then there's hope for recovery. And I have the website link there if you want to look at the source for that information. I think it's also important to address this idea of drug rescheduling. Um, so the Controlled Substances Act creates different drug schedules to regulate drugs based on their medical value, abuse potential, and safety, right? So cannabis in particular is a Schedule 1 drug, which may be surprising, which Schedule 1 drugs indicates there's a high potential for abuse and no accepted medical use. This is still, despite the fact that we have medical cannabis in a lot of states, this is still what the scheduling looks like. So scheduling is from low to high, meaning the lowest numbers, specifically drugs under Schedule 1 and 2 of the highest abuse potential, and Schedules 4 and 5 are things like benzodiazepines like Xanax, Ativan, Klonopin, and cough syrups that have the lowest, which is interesting because we see a lot of high abuse potential with drugs like Xanax and even cough syrup when people can't get a hold of other things, prescriptions for other things. And so that information at least was at some point on the DEA.gov site. So you can access it there if it's still there. So you might be able to guess now why I'm bringing this up. So if we can't properly determine a drug's potential uses due to restrictions with scheduling, it's really hard to develop new interventions in this area of harm reduction. So the rescheduling not only affects public access, but access for medical research purposes. That's how we learn how these drugs work. We have them in a controlled environment. We understand the potential, uses. It's a really complex process, drug rescheduling, and it involves a lot of regulatory agencies, including the FDA, the DEA, NIDA. So this traditionally can't be completed with an executive order. NIDA is the National Institute for Drug Abuse, by the way. And as I'm talking through the policy context, this is current administration notwithstanding, right? So there's a lot of changes currently going on in our country, and with our current administration. So I'm speaking to traditionally the way things have run in relation to these different agencies. So understanding legalization versus decriminalization, I think is important too. So legalization means there's no legal consequence for the use of a drug, right? So we have legal cannabis in certain places, right, for medical use, for recreational use in some states. No legal consequences for use of that drug. If we're talking about decriminalization, we're talking about a lowered sentence or punishment for the use of a drug that doesn't result in jail time. So example, like I said, legalizing the sale of cannabis versus decriminalizing it, or decriminalizing use, or allowing under a certain amount to be have a lesser offense, or distribution of a certain amount to be a lesser offense. So the U.S., as I said, takes on these battles sort of state by state. There's no accepted, policy. Just to contrast that, in Portugal in 2001, they completely decriminalized drugs. There's certainly been recent backlash on that. But that's sort of the other extreme, right? So as with any, social policy, if there isn't the infrastructure or community supports in place to manage the change in policy, the policy is not going to be, successful. So my example of that is, look at the Community Mental Health Act of 1963, right? So we wanted to remove people from harmful institutions where they weren't getting enough care, they weren't getting the proper care, they were even being abused in some cases. And so President Kennedy at the time signed this Community Mental Health Act in order to get people out of institutions and into the community and receive their mental health services there, which on the face of it seemed to make sense. However, if you don't have the proper funding, right, to be able to support those community providers, and you don't have enough of them, right? As we've seen in the aftermath of that decades later, you know, it doesn't work as well as we had hoped. So if you don't, so if you can have a policy, the point being you can have a policy, but if you don't have the infrastructure to support it, it's not going to be successful in the community. Even in the harm reduction space, there's racial inequalities. So Black and Latinx individuals who use drugs are actually less likely to receive naloxone or overdose prevention training as compared to whites. And this only worsened, of course, like everything did, right, in 2020 with the pandemic. So there was an increase in overdose deaths of Black, Native American, and Latinx individuals as compared to whites. And this is, again, we can't divorce this from the greater context of housing, employment, inequalities in targeted law enforcement, right? So I really want everyone to understand that drug use doesn't happen in a vacuum, right? It's not just an individual problem. I think we like to do a lot of blaming, societally, about people making certain choices. And I really want to highlight with this continuing education that drug use doesn't happen in a vacuum. It's really tied to a complex web of other social inequalities. So we need to view it within that context. And as social workers, I think we're well positioned to do that. So here's a health justice approach to harm reduction. So Hughes and colleagues in their 2022 paper suggest this approach for implementing harm reduction. So hiring people with lived experiences in the communities that they serve, which is so incredibly important. I think this is important in violence prevention circles too. If this really increases engagement with the community. The provision of institutional support for those Black and Latinx leaders who advocate for harm reduction community interventions, whether it's in an academic setting or an agency setting. And really centering community voices and addressing resistance to services. I think there's a whole movement of lived experience work where people with lived experience of mental health or drug use are then their voices are then centered to help in the recovery process for other people or in the harm reduction process for other people. So we really want to center community voices and not, again, take this overly paternalistic, moralistic view of we know better as the practitioners, right? They know what it's like to live in their skin. They know what it's like to deal with these issues every day. They know what their communities are like. And so if we come into the work with that perspective, I think it's a lot more successful. Okay, so we're going to move into some harm reduction interventions. We'll start with some therapy approaches. So many of you may have heard of motivational interviewing. It's really a style, excuse me, that focuses on the client as a driver of the change process. So the therapist is there to really amplify and highlight change talk, what we call change talk, which is any sort of comment, even if it feels like it's, something somebody says in passing that indicates that they're thinking about change. Because the goal is to help the client resolve their ambivalence about change. So the harm reduction focused practitioner will often use this approach due to its non-judgmental nature. And it's really made up of strategies that help client identify reasons for change and resolve their ambivalence. So it's on the focus is on the change process. So we're really focused on process and not outcome here, right? Ideally, we want the person to improve their quality of life through making the changes that they perhaps are saying that they want to make, but we're really process focused about getting them to that step. And this is a really significant part of motivational interviewing. It's called OARS. It's a great acronym, I think, to use for any therapy technique, right? Any sort of work with people, but it's associated with motivational interviewing. So OARS stands for open-ended questions, such as how can I help, right? Not yes or no, but how can I help? A for affirmations. So an example would be if you were working with a client and said, it's really, I understand it's really hard to accept help, and I'm glad you decided to come today. So you're affirming their decision to move towards change. I always tell people that, getting there is the hardest thing, right? Getting 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 in the seat, getting to the appointment, getting on the Zoom call or whatever. Like that's half the battle. If they're willing to do that and not stand you up and not no show, they've already made it 50% of the way to making changes, right? So reflective listening, are you might say something like, it sounds like you might be feeling, frustrated because of, previous treatment experiences. Is that right? Right. So you're reflecting back what they're saying, and then you're also asking for clarification on that. And then finally, the S stands for summarizing. So that I think is a really helpful tool because it can be very overwhelming for clients to sort of synthesize everything that's going on. And they might have really, sort of gone here, there, and everywhere in their conversation with you, right? So it's really helpful to have sort of a summarizing statement at the end of your session. So let's go over what we discussed so far today. Could be a way to do that. And again, ORS, specifically this acronym is associated with motivational interviewing, but you can absolutely use these tools, I think, um, you know, in general with other techniques. um, so harm reduction therapy is a specific intervention or technique, right? And so um, in their book on harm reduction in psychotherapy, Denning and Little define sort of this approach with the following principles. The client's goals are the clinician's goals, right? We want to align there. We don't want to have differing goals. The treatment should have as few barriers to engagement as possible. So if you're going to require complete abstinence from substances, that might not be possible. Um, I think it's okay to ask a client to refrain from using before or during a session, obviously. Um, but to expect that somebody's going to be completely abstinent might be difficult. Any reduction in harm or use is considered successful, right? So if they can reduce their use just when they're with you, right? Before they come to a session, if they can say, okay, I'm not going to, use anything, before, so I'm not, so I'm more present in the session, that's successful. Okay, so we're going to get into specific substances now, specific harm reduction interventions and approaches involving specific drugs. So first, we're going to talk about medical cannabis. So this is utilized for pain relief, or can be utilized for pain relief as an alternative to opiates, which have, as we know, a much higher abuse potential. Um, it's often used, medical cannabis can be used for rheumatoid arthritis to reduce inflammation, as an alternative to what we call NSAIDs, or like Advil or naproxen, things that are considered non-steroidal anti-inflammatory drugs, which can do damage to your stomach lining over time if you're using high doses. I've seen a lot of people use medical cannabis recreationally, but also I have people in recovery that use it to manage anxiety rather than benzodiazepines, which, again, that's a harm reduction strategy. So benzodiazepines have a very high abuse potential, and trying to use something that has a lower abuse potential, even if it doesn't mean remaining completely abstinent, is a harm reduction approach. I've also worked with a lot of clients who have chronic pain issues and have maxed out. When I worked in primary care in particular, there were a lot of people who had chronic pain issues from chronic conditions and sort of maxed out on these high doses of opiates. And so, um, primary care physicians would often refer them to pain management, neurology, different places depending on their issues, where they would get certified to get a medical card so that they have another option besides um, these high doses of opiates. So medical cannabis has been found to reduce dependence on other substances, um, including cocaine, alcohol, and nicotine. So I have another client who I've been working with who has had issues with alcohol for many years, and has a strong genetic predisposition. Many, if not most, of her family members have alcohol issues. Um, and so she has chronic pain issues. So she recently decided to get a medical card. And so, we were talking about how this could be a harm reduction strategy to lessen her drinking, which is um, the more detrimental substance for her in particular. So I think none of these strategies are without ethical considerations. I think we need to think about that. I think one of the main concerns that I've come across, particularly in the psychiatric community with psychiatrists, is the use of cannabis among teens, particularly those that might have an underlying psychotic disorder. Um, so being keeping that in mind, right? That um, you know underlying psychotic disorders tend to come out in the late teen, early 20s years. And so, if a teen is heavily using cannabis, is that going to sort of trip that switch in the brain, and cause that illness to come out, or you know cause potentially influence the experiences or the expression of psychosis that maybe wouldn't have otherwise been expressed. So the other aspect of this too is, sort of the changing landscape of employment and drug testing, right? So do employers change their rules due to the proliferation of legal drug use? So I think about like Colorado, right, being one of the, I think the first state to legalize marijuana. Like, how does that influence people that are going for jobs? How does it influence drug testing? Does it depend, on the profession? So, would you be comfortable, um, you know, with your surgeon being using medical cannabis for chronic pain that your surgeon had, right? Under what circumstances, and how do we say it's okay for some people to access the benefits of legalization, right, and not others? Um, do we specify it by job type? Do we specify it by, um, what are the parameters, right? What are the parameters? And again, I think going back to the policy context, when we don't have solid direction from a policy standpoint, and a regulatory standpoint, it's difficult to sort of put these parameters around use. Um, and I think the more we're able to regulate these things, the better we all have a blueprint of, how we can guide our clients, and just societally how we manage with the introduction of these substances into our um, day to day, right? Into our, not, moving them from being illegal to legal. Um, so there's a lot of interesting ethical things to think about there. But I think, again, as we continue to highlight the policy context, that we can't divorce that from the clinical here. So opiates are another area where we can consider a harm reduction approach. And so, one of the strategies in relation to opiates is overdose education and naloxone distribution. And the idea behind this is, if more people understand what's happening during an overdose and how to help, fewer people will die. And as I said before, if we can get fewer people to die, we can get more people to recover, whatever that looks like for them, or reduce their use. So, and as we saw previously, not everyone has equal access to these interventions. So it's important to also recognize the social inequalities within harm reduction as a strategy. But if we provide standardized training for use by everyone, including non-medical bystanders, this can help in an emergency situation. And research has shown that this strategy has reduced overdose deaths. Um, Another harm reduction strategy in another harm reduction strategy in relation to opiates are needle exchange programs. This is really meeting people where they're at in the height of their addiction. And this means offering clean needles and injection equipment. And also, some places will provide social and health services, including HIV testing, or linkage to on site treatment or treatment within the community for drug and alcohol, if that's what they want, or mental health treatment. It's really this idea, these types of programs are really meant to engage people that are traditionally marginalized from mainstream healthcare settings. And there's somewhat, there's been a lot of controversy over it. I know there's good work being done in order to move these programs forward and try to reduce, again, the goal of reducing death and moving people along the continuum of, um, you know, from higher risk to lower risk. Also, with needle exchange, you're also thinking about reducing the spread of disease with people using dirty needles and spreading um, illnesses that otherwise, if they were using a clean needle, they wouldn't be um, contracting or um, giving to others. There's also safe injection sites, right? So these are sites that are supervised by health professionals where people who use drugs can use without legal consequence. And we're going to continue to see tension between the state and federal levels, regardless of what administration we're in, right, in terms of harm reduction interventions such as this. So it's a similar idea behind needle exchange that's behind needle exchange programs, but the idea is reducing disease, preventing death, right? Um, these sites still remain illegal under federal law in the US, despite research that suggests they reduce overdose deaths. So, again, we're looking at state level interventions. Rhode Island and New York City do have them. Um, and I think in 2003 is when they first introduced them in Vancouver, which is in Canada, which is way ahead of us. But we'll see what the future of these types of interventions ends up being. Um, and I think there's a lot of, again, at the policy level, you can see a lot of back and forth and sort of moralistic conjecture about what this means, what we're encouraging, quote unquote. Um, there's been criticism that these types of things encourage drug use rather than looking at them as preventive measures or as harm reduction strategies. So you're going to see a lot of tension between these kinds of interventions at the state and federal level. Um, so there's been some worry about if we make naloxone widely available, this is going to increase people's consumption, which I don't think the research has really borne out. Um, and again, as we said, not everybody even has this equal access. Um, you know, if we're additionally, if we're avoiding involving trained medical personnel and people, avoiding people um, need to receive additional medical care, are we sort of missing opportunities? So um, part of that criticism, I think, is that, okay, if we're encouraging lay people to administer naloxone, it doesn't allow for people to enter the medical system and receive, maybe additional care that they could use. But again, this is a group of people that's often marginalized in the medical system and hasn't had great experiences. And the average medical professional isn't necessarily used to or receiving training in working with people that use drugs. And so there's sort of a I think a little bit of an anxiety or a frustration among medical professionals in not having the skills and not knowing how to help. And so therefore, sometimes I think that comes off as dismissive or further sort of marginalizing of this group of people. Um, so far, research hasn't really shown generally that crime um, people well it's not shown generally that crime is increasing, but some places are sort of walking back their policies, um, and a lot of that has to do with public outcry, of drug legalization. So, um, and again, it has to do with how we're studying this. So, for example, overdose deaths in Oregon have increased, though it's really unclear whether this has anything to do with decriminalization there. The research hasn't really quite caught up with that. And again, like if we're not funding and supporting this kind of research, it's hard for us to know what's going on, what's the outcome of these interventions that we're utilizing. Um, so moving to alcohol, we're going to talk about some interventions for adult populations. So college students in particular have the highest prevalence of alcohol use disorders out of any other age cohort, which may or may not be surprising to people. I think college age drinking is very much a social norm for a lot of people. So I imagine that's, why they have the highest use disorder of anybody out of any age cohort. So with this population, you can use a combination of approaches that involve motivational interviewing or behavioral skills, norms clarification, and web interventions have also been found to be effective in decreasing drinking behavior. I think it's important with college students to recognize that you're going to have a different approach potentially due to, as I said, the developmental norms of this group. So abstinence, again, might not be feasible given the age and stage that they're in or their willingness. Another population I think is useful to talk about interventions with is homeless adults in terms of alcohol and harm reduction in relation to alcohol specifically. Um, so many, if not most, at risk group, and they present as often treatment resistant based on a variety of things, including oftentimes severe untreated mental health issues. So, um, and a big, a big, again, policy context with this is housing, right? Housing is often contingent upon abstinence from alcohol. And the penalty for use, if you're in a supported housing program, of which we don't have enough to begin with, but if you are in one, right, it's often the penalty for use is eviction. So if we utilize a harm reduction approach for homeless adults who use alcohol, um, this involves removing this kind of abstinence only contingency. So Larimer and colleagues in their 2009 paper found that less drinking and less drinking and intoxication, as well as over $2,000 saved monthly in expenses for their non-contingent housing group. So they studied two groups in which one in which was where the participants' housing was contingent upon abstinence, and one was not contingent upon that. And so they found that the non-contingent group actually drank less and were intoxicated less and saved some uh, money in their monthly expenses. Yet again, in contrast, another study that found no difference in use between the two groups, but improvements in other measures. So not, not for nothing that one of those other measures, improvements in other measures, was less time spent homeless, which is significant. So, again, we know that things like housing, access to care, access to food, things like that are really important and part of the social context and picture in treating folks with drug use. So ethical considerations. How do we understand this? So should harm reduction approaches change for teen drinking versus college drinking, right? How do we support teens? Um, you know, most interventions for teens are going to, include an absence approach. Is that, you know, that's not really a harm reduction based um, intervention, right? What do we do differently? Do we treat teens differently than college age drinkers? Will non-contingent housing reduce alcohol use consistently over time, right? How do we square this with treating the mental health piece, right? So how do we effectively treat a client's mental health issue if they have a co-occurring mental health um, and substance abuse disorder? So how do we effectively treat the mental health piece if we can't significantly reduce the substance use, right? And how do we ethically study this population also? So there's a lot of different questions around, um, you know, studying marginalized populations and ethically approaching that, as well as, certainly there's a lot of societal or policy state by state backlash over housing, and particularly there's been a lot in the news in New York City about how to reduce the city's homeless population, many of which are chronically mentally ill, some of which might be using drugs. So there's been a lot of conversation about how do we ethically address that societal issue while also maintaining, as social workers, the dignity and worth of the person, right? So thinking about our ethical code. So New York City is just one example of a city that's grappling with that. And there's, you know, many opinions, right, about how that should be handled there. So I wanted to talk about psychedelic therapy as well as a harm reduction strategy. It includes the use of certain psychedelic drugs, right, as either part or adjacent to the therapy process. So drugs like MDMA, psilocybin, which is in what you've maybe colloquially heard as magic mushrooms, LSD, etc. So psilocybin is the chemical component found in the mushrooms that can produce this hallucinatory state when ingested. Um, so there's been some um, research based on using psychedelic therapy for treating alcohol use disorder. So researchers have looked at using psilocybin to treat heavy drinking. And so in one study, they found a large reduction in drinking, which was dose dependent on the psilocybin dose observed at the 32-week follow-up, and also in combination with psychotherapy. So again, who's able to study these things, right? This is mostly being studied in a controlled environment in academic settings. Johns Hopkins does a lot of this research. Um, I think NYU does a little bit too. But again, if that all depends on funding, right? That all depends on the ability of institutions like this to have the funding to study these things. And drug scheduling has a lot to do with that. So, it's very complicated to study these things if they're considered Schedule 1 or 2 drugs, because those are the ones that have the highest abuse potential according to federal law. So again, the really sort of emphasizing the societal context of even studying these drugs is really fraught with sort of conflict. Um, Psychedelic therapy has also been studied in treating complex trauma. A lot of this work is being done with studying veterans. So the use of MDMA for PTSD. I've also heard use of ketamine um, for depression and PTSD, use of LSD, psilocybin, MDMA, particularly for anxiety related to terminal illness. There's been a lot of stuff in the media about that as well. Um, Again, using this in clinical trials because the legal status of these drugs is, as I was saying with the scheduling, it gets really complicated. So, but there is some, research to suggest that that psychedelic therapy, i.e., using psychedelic drugs in as I said, adjacent to or as part of therapy interventions, is helpful for complex trauma. So I think another thing to consider here is how do we work within the boundaries of a non-research based setting. There's a lot of uh, popular media, and I don't know if you've heard of How to Change Your Mind, Michael Pollan's recent book about these sort of guides and people taking psychedelic drugs with guides. Um, Again, that's sort of a no man's land of unregulated uh, stuff. So again, if we could understand how to better regulate these things, including treatment interventions, we would have a better understanding of what's working, what's not, what's safe, what isn't. So it's important to consider sort of how we work within the boundaries of non-research based settings. So clients really need to do their own research. Um, we as clinicians need to educate ourselves on these things. um, and it is important, I think, to have clear boundaries about not coming to session while under the influence, so people understand what your boundaries are within the space of your treatment room. um, and really, since these drugs are illegal and really only used in a clinical trial context, anyone that calls themselves a guide in this area really needs to be strongly vetted. So we want to encourage people to really do their research and do things if they're going to work with a guide, to do that safely, have some backup plans in place or extra supports in place, so that they can explore this as safely as possible if that's what they want to do. um, um, okay, so I think, again, in researching harm reduction, or in conducting research in harm reduction, we have to understand that research with marginalized people is really fraught with risks to participants. Um, and it's, might be difficult to get people to consent, right? Particularly to ethically consent, right? If they're under the influence. So we have to sort of think about, you know, um, the ethical implications of, studying sort of drug use in real time, the legal constraints, um, the and the need to improve communication, and view people view supporting people who use drugs as a human rights issue, that really highlights the social and economic inequalities, um, that are that we deal with every day. So I think, we need to consider a lot of these different aspects, in terms of thinking about studying populations that use drugs. Um, so I think, as clinicians, if you're thinking about, or maybe social work practitioner in an agency that's maybe not social work minded or social work focused, if you're thinking about utilizing harm reduction strategies, I think, it's a good idea to do your research, and to look into what, strategies or techniques might be possible within your context of your agency or your practice. Um, and I think it's also just it's an attitude. It's an orientation, so I sort of see myself as a harm reduction, as operating with any client, from a harm reduction perspective. Any client that's engaged in any sort of harmful behaviors, whether it's drug use, eating disorder behaviors, cutting, how do we reduce, you know, the instance of that behavior? Because when you're talking about behaviors that are harmful to people, you're also talking about their coping skills. Um, and it's really not advisable to tell somebody, okay, well, we're going to take this coping skill away from you. You need to stop doing this because this is bad for you. Before we've given them, first of all, hope, second of all, other options. So if you take somebody's coping skill away and they don't have any other options to cope, it's not going to go particularly well. So we have to have something else to offer them. Um, and that is a process, right, of finding what that is for them, and aligning with what their goal is. If they want to um, completely stop using, I have plenty of clients who have said, yeah, I know that, my drinking can be a problem, or I know that, when I'm getting up to X amount a day, it's starting to be a problem, but I don't really want to stop completely, right? So those clients are sort of putting it out there up front that, you know, abstinence isn't going to happen for me. It's not what I'm interested in. I am interested in reducing, right? But I'm not interested in stopping completely. And so that's, again, if we're taking a motivational interviewing perspective, that's change talk, right? We're focusing not on the fact that they don't want to stop completely. We're focusing on the fact that they um, want to move towards reducing, and that's our goal. So I think it takes some time to reorient ourselves to this way of thinking. Um, I don't think societally we're really oriented to a harm reduction approach, or even any sort of preventive approaches. If we really want to go 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 there, right? We're very reactive, um, and so I think, again, drugs are not going anywhere. We're never going to eliminate, drugs from society. So we have to learn how to help people reduce their um, reduce their use or reduce dangerous behavior. Um, I went to, I think I went to, it was a training, in which there was a harm reduction practitioner that did a presentation, and she she shared with the audience that, for her one particular client, moving from cocaine use to, I don't know if it was marijuana use or cannabis use, or heroin, maybe something that was, still dangerous, but not as dangerous to her as the cocaine use was part of the goal. And she admitted as a practitioner, like, I feel kind of some type of way, right, about saying, okay, the goal is to use heroin, not cocaine. But for that particular client, she was moving from a higher risk behavior on the continuum to a lower risk behavior. Even though it's not, none of these behaviors are without risk, right? But for her, for that particular client, that was the goal, and she felt good about being able to move, further down on that risk continuum. And so I think it's a real paradigm shift for us as practitioners to see that that as potentially a goal for a client. um, so again, we really need to support clients where they're at. Harm reduction is uh, a non-judgmental, shame reducing, uh, y- you know approach that centers the client voice in their treatment. And we want to reduce risk, right? That's the whole idea, is reducing risk. um, we're not trying to change uh, the person from, to move them to an abstinence only framework. We're not trying to completely change their drug use behavior. It's just focused on reducing risk. And so that can be, again, like I said, a paradigm shift, and something that uh, is a real challenge.